Have your friends make their way, start making, just please send a message to all of your friends to start making your way. And the speakers for the next session, I would like to make sure that they are ready. So, this next session, we have some excellent speakers again. There's no common theme as such, but we are going to hear about liver problems from the eminent Dr. Shiv Sareen. We are going to hear about nasal allergies from very eminent Dr. Chanchal Pal, who's my colleague here. And I'm not sure about Dr. Dinesh Vyas from California if he's here. And last but not the least, Dr. Lokesh Adara, who has been instrumental in setting up and moving along the topic of changing scenario of medical education in India. So just before we start our next session, for those of you who are visiting from the US and you need your CME credits, please make sure about the scanning, the QR code scanning with the EMED events. And at this point, while we are waiting. So we are very thankful to EMED events who have been instrumental in getting us accredited for the CME. And we have Shreya Gupta with us. She is representing EMED events. I want her to say a few words. Thank you, Shreya.
Good afternoon, everyone, and thank you for this. So I'm Shreya. I'm interim CFO at EMED Events, and EMED Events is a global medical education marketplace. We help connect healthcare professionals from around the globe with CME providers. And we started as a Harvard Innovation Lab starter, and now we have more than 500,000 physicians visiting us every month from 168 countries. So, what we do for physicians and CME organizers? If you are a physician, you can visit our website. We are a CME marketplace. You can book and reserve your conferences, CME or non-CME conferences, by state, by specialty, by location. We have live, online, hybrid, all type of CMEs. We have cruise conferences. We also plan CME travel. We provide free CME courses for physicians. And now we have also started producing and giving state mandatory courses for all the physicians. We also have a very personalized dashboard where we do CME planning for all healthcare professionals. We provide them with a very secured credit vault where they can store all their CME certificates at one place. They can go through daily medical news through their personalized dashboard. Also, we have recommendation engines, AIML setup on our platform through which we show you that what other physicians are taking up in courses within your location and within your specialty. And we also recommend the same for you. We also have a speakers bureau. So for all the speakers in API and in this house, we welcome you to attend our speakers bureau and be part of EMED events speakers panel. We promote speaker profile and we help speakers network within their peers and connect them with the right organizations. We also publish the work for all the speakers and provide them a place to provide medical blogs. If you are an organizer, we help you do end-to-end online CME hosting and publishing. We do webinar creation for all the organizers on our platform. We provide a very customized conference page through which you can track all your CME activities and all the demand and supply on our platform. We also provide registration partnership in case of online conferences, and we do competitor analysis and data mining through which you can get better insights of your conference and you can make it better in future. We also provide accreditation support both nationally and internationally. We are also providing accreditation for API in this event. We have been API's accreditation partner in past as well and hope to be their partner in future as well. We provide a very targeted marketing support because we have our own healthcare professional database of 2 million plus healthcare professionals within United States. So we do a very targeted marketing for through that database and provide traffic to the conferences of the organizers. We also provide end-to-end in-person CME conference support, where if you want to create a course, you want to of CME in US, we can do it for you. If you want to create a cruise conference, we can provide it for you. If you are looking for a speaker for your conference, we can match you with the right speakers from our speakers bureau. If you want to bring in traffic to your conference, we can do event marketing for you through our targeted marketing using our own database. So we do end-to-end in-person CME conference support. And apart from this, we are currently raising funds as well, since we are a startup. And in past, we have raised funds, and currently we are doing a $4 million bridge funding round. Some of the RP members are already our investors in EMED events. And if anyone is interested to invest, you can reach out to me for that. We also have a lead investor in this round, and EMED Events is led by C2B Capital. Thank you so much.
Yeah. So you were talking about investing. So when I remember a couple of years back, I was a judge at a startup competition, and that's when EMED Events was one of the presenters, and I was blown away by the concept, like putting together of a CME, like it's a whole package deal, right? You like a travel agent, like a full concierge service, and that's when I met Priya at that time, Priya Kurapalli, who's and yeah, so I'm glad that it's taken off in such a nice way and it's growing. Congratulations to EMED Events. So for the QR code, nahi? So there's as you're walking in, you see a board with a QR code on it, just before the red carpet area. Please make sure you scan that QR code. You register yourself for the CMEs.
Is it one time?
Do you know if it's just one time scan?
Yeah, it's you can scan it one time and fill the form, and then we'll get the information. And if by any chance you miss that, then you can reach out to Dr. Indipal and share your information with them, so that we'll get the information. Because if you don't scan and if we don't have your information, we cannot provide you the certificate. So it's really important. Thank you.
Alrighty, thank you. So we're going to start. So Dr. Lokesh Adara and Dr. Chanchal are my next two speakers. It's my privilege and honor and great pleasure in introducing Dr. Chanchal Pal. She has over 36 years of experience at ENT. She spent most of her life at Manipal. She's currently serving as a senior consultant in ENT at Indraprastha Apollo Hospital in Delhi. She is the past president of IMA of South Delhi branch, president of Ear Care Foundation of India. She is involved with the Lions Club as a past president, and her passion is planting trees. So she has planted more than 5,000 trees herself, and she has written books on effects of noise pollution, especially on the cardiac health problems that noise pollution can bring. And she has interest in rhinology and laser sleep surgery. So without much further ado, yeah, that's a QR code that you need to scan.
Not for me, that for
I know, yeah. So without further ado, we can have Dr. Chanchal's presentation. Dr. Chanchal Pal.
अभी QR code रहने देना. Thank you so much. I think everybody has scanned the QR code. If not, then we'll play it again. Is that all right? We should start with presentation. Thank you, Dr. Indipal. And Happy New Year to all of you. So at the outset, I'd like to thank API and organizing committee of 17th Global Healthcare Summit 2024 for giving me this opportunity to be part of them and also present here. So in my presentation, I've chosen allergic rhinitis and sinonasal polyposis. The topic looks simple, but it involves millions of people. That's why I've chosen it. All of us are dealing with it day, night, and day in. So let us see what is recent. My topic is more of a buffer. I thought we'll save the time, so I prepared it less so that we can have more time for more speakers, being a part of the organizing committee. So why I have taken allergic rhinitis as a topic rather than taking robotic surgery or maybe sinus surgery? The reason is its epidemiology. World over 400 million people suffer from allergic rhinitis. And United States itself, as reports say, fifth most common chronic disease is allergic rhinitis, or would say upper respiratory allergy. And out of them, 30% adult and 40% of children suffer. India in urban scenario is almost the same, especially in children. But thanks to our urban lifestyle, we have lesser allergy. But we are catching up with you in that also, with US counterpart. Not only it's the number and epidemiology which makes important allergy as an important subject to be discussed, is consequence too. Apart from symptoms, only the person who suffers from allergy in the nose knows what is the agony they suffer from. People say sirf jukam to hua hai, but it's not just jukam. The nose remains blocked, cloggy, and they're sneezing at the wrong time, and that life is difficult for them, and they really want to get rid of these symptoms. Not only that, it also leads to sinonasal polyposis, recurrent attacks of rhinosinusitis with related complications, which as a surgeon we deal day in, day out, allergic fungal sinusitis, allergic bronchitis, and asthma. If not controlled, as area guidelines says, that if nasal allergy is not controlled, it's difficult to control allergic bronchitis and asthma, because as goes the nose, so goes the bronchi. So it is important that we take care of allergic rhinitis, which is simpler to handle than we do for bronchitis. Management, all of us know, all these things are there. Lifestyle modification, medication, immunotherapy we have been doing. Biologics are new. For me, lifestyle modification is the most important part. We need to spend time with the patient. Patient education is important, and make sure that they recognize their own allergen and avoid dust catchers and pads and other things. Why I'm talking about the only recent advances. So recently we have air purifier in almost all the houses in the urban area because of the pollution and increased pollutants. But still, most of the time, only one thing I tell my patients: to avoid any dust catcher, remove all the horizontal surfaces, keeping things outside, remove all your carpets, and remove thick curtains, and do vacuum cleaning or mopping rather than dusting. But air purifier is at least in the night time, whenever you're in the bedroom, that is takes care of allergens to some extent. But in spite of all the complete avoidance of allergens, the trigger is not possible, and so we have to resort to medication. Antihistamine is the most common, which all of us are using. A word about Montelukast: when you have polyps or bronchitis along with that, then only use Montelukast, because there are recent reports which are coming which say that there are symptoms of depression and even suicidal tendencies in some of the patients, especially adolescents, and with Montelukast. So we have to be careful about the combination. Yes, if the patients have polyps and bronchitis, do add them. All these medicine which I have mentioned, we have been using from CPM to up to Avastin, depending upon the patient's response. But the latest one, Bilastine, has been proving to be a non-sedative, peripherally acting, and equally effective. So when I talk about the last decade development, Bilastine one of the choices which can be added to your armamentarium. Decongestants, we usually avoid oxymetazoline, xylometazoline, except when you have rhinosinusitis. Yes, azilastine, though bitter in the taste, has given good results. So what I'm saying, that what we choose now, maybe you can choose azilastine over the above two. Systemic decongestant, again, avoid because they cause hypertension and prostatic symptoms unless the patient has a very runny nose. Steroids, yes, steroids are yes for allergic rhinitis, especially if you have polyps. And out of these three, mometasone is supposed to be safest, even given to the children as a younger age group and for longer period of time. And systemic steroids in case of polyps and asthma we need sometime, and of course for nasal polyposis we need systemic steroids. But for me, deflazacort has given better result, and especially in COVID time when we give this, the sugar level didn't go that high as they go otherwise. Usually in allergic rhinitis, pure allergic rhinitis per se, avoid steroids. A word about sinonasal polyposis. Yes, decongestant, anti-allergic, topical systemic steroids. Systemic steroid is a must for polyps before you take this patient for surgery. But FAST, the functional endoscopic sinus surgery, which is developed over the last 15 to 20 years, is something which is going to stay. And thanks to good armamentarium with us, cameras and good light, we are able to clear almost every nook and corner of the sinuses of the polyps. And this is one thing which is recently we have got better of. Of course, as endoscopic polypectomy, as a surgeon, I can vouch for it, functional endoscopic sinus surgery, and remove the obstruction by septoplasty or turbinectomy, because polyp is not only produced by allergy, but you can have the triad: allergy, infection, and obstruction, which makes polyp to come over in the nose. That's why all allergic patients don't have polyps. So you have to make sure that you remove all the obstruction and hence infection also. In spite of all this, we are still away, which cure is a mirage. That's why we keep discussing allergy. Available therapeutic options are achieving a lot of relief with these all the things which I talked, but a cure. The moment the patient stops allergic medication, after some time they are coming back to you with same. So why not think further? It's been well thought, that immunotherapy has been helping. Allergen is giving gradually increasing doses till maintenance doses are reached. Aim is to increase tolerance and decrease the pathologic immune response. That is the aim. So that's how immunotherapy works as in any other disease. So what we have to do, identify the allergen and modify the immune response. How do we identify allergen? Skin prick test and serum blood test, that is ELISA. Which is better out of them? Skin prick test, which is done, is OPD procedure. It done in 40 to 45 minutes. In adults, it's done on forearm, and children in upper back. Around 60 in India, around 60 allergens are tested, like pollens, molds, pet, denders, dust mites, and foods. We have common allergens which we have identified, and we test for that. It is not a painful procedure because lancet is used, which barely penetrates the skin surface and don't cause bleeding. Basically, I also was worried about the pain part, especially in children when we started this. But to my surprise, most of the patients, I asked them specifically after testing, was it painful? They said no. So probably it is not as painful as we think, except for, yes, children and young adults who are worried or scared. For them, you can go for allergen test. But still, I'll prefer skin prick test because these give quick result. Not only that, as compared to ELISA, which you do immunoassay, it is more sensitive, far more sensitive than ELISA test. So again, skin prick test is low risk, simple, inexpensive, well standardized, and more sensitive as per this report, as Sharman and Kumar say. And also we have started preferring skin prick test over the ELISA test. Maybe 10 years back we were doing mostly ELISA. Once you know that what are the allergens, it is usually not one, but you are getting at least 5, 10, 20 allergens which are positive, and you start thinking, what should we do? Immunotherapy is the choice, which can be subcutaneous immunotherapy or sublingual immunotherapy. Both are effective, but it is difficult to give subcutaneous immunotherapy because it's a long therapy. Immunotherapy, all of us know, it goes on and on, and to give injection for such a long time, the patient compliance becomes questionable, and most of our patients used to stop halfway. But since the sublingual immunotherapy we have started, the patient compliance is much better, and it is safer with fewer systemic allergic reaction than SCIT, and more comfortable for the patient since allergens are ingested rather than given injections. Here, I would like to also mention when in a skin prick test, when you are starting in your clinic, especially the youngsters, I prepared my talk especially for students and youngsters. Whenever you start anywhere, make sure that you have kit ready for anaphylactic reaction. It should be done in presence of a doctor, and you should be always ready with anaphylactic reaction. Though rare, it is a possibility would touch. So far, we didn't get any, but any time we can go through that, may find one of those patients getting anaphylactic reaction, so we should be ready for that. So sublingual, coming back to sublingual immunotherapy, which is safer and more effective. So long-term real-world effectiveness, I've been mentioning all the citations so that we know where we are. Long-term real-world effectiveness of allergic immunotherapy in patients with allergic rhinitis asthma. This is a result from REACT study, a retrospective cohort study, where around 46,000 patients of allergic immunotherapy were treated, and which was matched with the control subjects of 14,000 who were pre-existing asthma cohort. The results were the effectiveness of allergic immunotherapy in real life was confirmed. It had sustained reduction in AR and asthma prescription, prevention of asthma exacerbation, and improved and sustained long-term asthma control. The findings emphasize that allergic immunotherapy is a safe and effective treatment option for patients with respiratory allergies, as per this particular report, which was done in 2021. I think I've also vouched with this that we have been seeing these patients who are responding better with, I won't say it will, they will stop having any allergy, but requirement of medicine goes down. Some of the patients don't need at all, some patients require, but requirement goes down, symptoms get better. Only drawback, it is a long-term therapy. Patient compliance is important, and the follow-up is important. Almost for 1.5 years to 3 years, we have to give immunotherapy with booster doses, but it is very safe. Now, coming to biologics, which is the latest one, which we in India we don't have much experience, but yes, we should know about biologics, especially our US counterparts are using a lot. So what are biologics? They are medicinal products made of biological process, isolated from natural sources like human, animals, and microorganisms, produced by cutting-edge biochemistry chemical methods. Biotechnology is used to produce them. So these are the biologics which have been now recommended. So a few slides about biologics. Biologic therapy for allergic rhinitis and nasal polyposis. This was reported in 2020, where allergic rhinitis and nasal polyposis, why do we use biologics? Because these are type 2 high disorders and expression of interleukin IL-4, IL-5, and IL-13. And neutralization of IgE with anti-IgE has proven efficacy in allergic rhinitis, what omlizumab does. Blockade of IL-5 by maplizumab and reslizumab and benalizumab, and dual blockade of IL-4 and IL-13 by dupilumab is effective in nasal polyps. Difficult names, isn't it? Zumabs and lumabs. But however, as per this report, these agents are extremely expensive, and future studies are essential to evaluate their cost effectiveness in comparison to current medical surgical therapies. So I'll just quote few studies which will establish their effectiveness. So where various metrics have been used in different, several studies are still going on, and you should understand these metrics we'll be talking about time and again. Sinonasal outcome test, that is not 22. Most of you must be familiar with the allergic rhinitis. It's not 22 is a format where you have 22 questions. Sinonasal outcome test. Nasal polyp scores will be mentioned again and again, NPS, and nasal congestion score, NCS. Sinus ossification scores, University of Pennsylvania scores, and smell identification test, UPSC score. Drawback what I found in different studies, because they've been using different markers, so sometimes it's difficult to compare two studies from one to another. But still, you have some conclusions which are coming along. So biotherapies for allergic rhinitis and nasal polyposis. Why I'm adding nasal polyposis? Because they are more effective in nasal polyposis. And not only that, the patient with nasal polyposis are find really difficult to live with that. As nose is totally blocked and there's high risk of fungal sinusitis and having secondary ophthalmic complication or intracranial complication. So we have to deal with this patient so that we take care of them. Biologics that target IL-4 receptor, IgE and IL-5 receptors, and have been shown improvement in of various metrics. That is what this study says. Dupilumab, which is the first biologic approved by the treatment of chronic rhinitis with nasal polyposis after phase 3 trial, probably because of its dual action on IL-5 and IL-13. Benalizumab is also given a positive results. So again, they say that this study is almost June 2021, which says that future efficacy studies and risk benefit and cost analysis. Again, they emphasize the cost analysis of these biologic need to be performed again. They recommended further studies. Though dupilumab has been found to be good for a phase 3 trial. Again, another study which said biotherapy for the asthma and coexistent chronic rhinosinusitis, which is again a real world study where 247 patients were taken. Biologics used were omlizumab, moplizumab, benalizumab, reslizumab, and dupilumab. There was significant improvement in CT score and SNOT-22 score in them. Omlizumab reduces the just mentioned, because omlizumab is very commonly used, so you should know that it reduces the CT score, but not SNOT-22 score. SNOT-22 score is mainly clinical score, and where the patient's response is important. Omlizumab decreases CT score, but not SNOT-22 score. FAS, endoscopic sinus surgery, was performed in 84% already, but 22% of they underwent surgery post biologic intervention. That's important. As a surgeon, I emphasize that 22% all fit again needed surgical intervention. That doesn't write off the biological agent, of course. These real world study results may influence future clinical application of biologics. Here I like to declare that, because I've been using different agents and talking about, there's no conflict of interest, and I don't know any company which is producing biologics in India. So all the studies I'm mentioning is with quotation, and it's been the study which have been done, and I'm concluding from them. Which is the best biologic of nasal polyps? That's a declaration of important before I come to this slide. Dupilumab, omalizumab, or mepolizumab, which is a network meta-analysis was done, where 9 studies were taken. Around 1,000 patients were patients were there in those 9 studies, and 3 different biologics were used: dupilumab, omlizumab, and mepolizumab. Ab tak to naam yaad aa gaya hoga shayad, so many zumabs are there. And sometimes I feel, why don't they keep something simpler? And placebo was included, of course, for comparison. So coming to result, dupilumab, the best efficacy in terms of nasal polyp score, NPS, SNOT-22 score, penicillin smell identification scores, the nasal congestion scores was supposed to be has the best efficacy in these scores. Omlizumab ranked second in efficacy in terms of SNOT-22, UPSIT, and NCC and circa values. All the metrics which we were talking about, which was ranked second. And moplizumab ranked second in the efficacy in terms of NPS and circa values, and had the highest risk and adverse event. So what they conclude, this study was done in 2022 by Zhang, Gong, Wang et al. And they concluded the best, based on the efficacy and safety, dupilumab is the best choice, and omalizumab is the second best option for chronic rhinosinusitis with nasal polyposis. Although moplizumab ranked second in efficacy, its highest risk of in allergic rhinitis. So that is these 2 agents finally should be kept in the mind when you are using, because their cost is still skyrocketing. Now, a comparative analysis of endoscopic, this slide is close to my heart being surgeon. A comparative analysis of endoscopic sinus surgery versus biologics for treatment of chronic sinusitis with nasal polyposis. Once you go through the entire study, I realized that biologics are definitely effective, even in the polyps, more than what steroid do. In this study, only 111 patients were taken. The conclusion was endoscopic sinus surgery and dupilumab offer comparable improvement in SNOT 22 and smell identification at 24 weeks of starting. So it was comparable in their report. Compared to omlizumab, endoscopic sinus surgery offers superior SNOT 22 improvement. Functional endoscopic sinus surgery or endoscopic sinus surgery offers significantly greater reduction in polyp size as compared to omlizumab, dupilumab, and meplizumab therapies. That is understandable because your surgery, when you're doing, you're going from one nook corner of the sinus to another. Naturally, you're going to clear the sinuses better than what medical treatment can do. But this is very encouraging that both the drugs have comparable result when we talk about the patient's clinical result, that is not 22 score. So this is encouraging reports. So to conclude, what are the pearls? Nasal allergy is very prevalent allergy entity and ever increasing incident throughout the globe, thanks to air pollutions, urbanization, use of synthetic, urban lifestyle, indoor lifestyles. For what I keep talking, that's why I grow so many plants, and I actually talk about effect of noise pollution and air pollution on not only on system but even heart and cardiac. And I've actually come down to the conclusion that they are direct chemical effects of these pollutants to our cardiac system, not only through lungs, but they get absorbed, and their direct incidents are there, especially in pregnant women and young children. So definitely their allergies on increase. Add on our armamentarium in management in last decade, maybe air purifier, which has come to a new addition to our bedrooms. Belastin is supposed to be a good agent. Out of all, momentazone becomes the choice of the topical spray, steroid spray, because of its safety, which you can use for longer period time. Again, in steroid, deflazacort should be a choice of the salt, because of again its safety for the longer term. Skin prick test is there to stay. It's highly sensitive, has higher sensitivity than ELISA, and it's cost effective as well. Out of the immunotherapy, sublingual immunotherapy again is something which can be sustained. It is effective as well, but of course long term benefit has to be seen. Endoscopic sinus surgery is an excellent procedure. Only thing is that you have to tell the patient it is the first stage of management, not the last stage of management for the nasal polyp. Thanks to our good available equipment, cameras and lights and learning curves, we have come down to a better, safer endoscopic sinus surgery, which has become one of the routine surgery in our theater. And biologics, which we just talk, can be added if our patients can afford, especially US counterparts are using. We have used in COVID, but maybe we will use in routine cases comes earlier. So lastly, although there are dozens of available treatment options for allergic rhinitis and over-the-counter and prescription of antihistamine and corticosteroid, many people with condition still report reduced quality of life due to allergic rhinitis symptoms and treatment side effects. Successful management of symptom with medication requires strict compliance with medication regimes. Immunotherapy is effective but is time consuming and required significant patient commitment. It's almost 2 to 3 years. Omlizumab, a biologic that currently FDA has approved to treat AR and CRS with polyp. Moplizumab, also FDA approved to treat allergic asthma and CRS with polyps. Reslizumab and menarizumab are approved to treat allergic asthma. They have been approved for different conditions. So US counterpart must be knowing better what is the reason for that. Dupilumab, FDA approved to treat both allergic asthma, CRS with polyp, and has shown positive result. With that, thank you so much. Thank you.
Thank you, Dr. Chanchal. Actually, we happen to have our own Dr. Lokesh Adara, who's also an allergist, and he does use a lot of these biological agents in his practice. So I'll ask him to give his few comments on biological agents in the treatment of allergies.
Thank you so much. Because the students are here, Dupilumab, madam said that it does work for very well nasal polyps. We have maybe 30 to 40 patients, and it works. A lot of polyps don't smell. Even after surgery, they say the smell don't come back. But Dupilumab, the way it works, they smell coming back immediately. I'm sure madam mentioned. Those who want to take the exam, USMLE, they will ask for, they don't ask which, maybe they will ask Dupilumab or for polyps, but they will ask you in the step one, which IL receptor it works, IL-4 receptor alpha chain or ILR4RA. That's what the question going to be in the USMLE. That's what I mentioned. And also the Dupilumab, madam, eczema patients, it works very well. You have a lot of patients eczema. It is working for 2-year-old. One of my partners, pediatric, they started. It is amazing, the eczema, how the Dupilumab working in children, like 1 or 2-year-old. It's amazing work. Thank you.
Thanks for those comments, Dr. Adara. So it's I'm lining you up for that as the next speaker, Dr. Adara. As you just heard, he has been in practice in allergy since 1990, and he had done his fellowship in allergy immunology from Thomas Jefferson University in Philadelphia, and is of course he is a mentor to a lot of medical students and the residents. As you just heard, he was passing you some questions from USMLE Step 1. So, Dr. Dara, please come. And actually, while he's coming up, I see Dr. Shiv Sareen is here. So, of course, we'll be remiss in not recognizing Dr. Sareen's excellent work in putting hepatology on the map, not just in India, but in abroad. Dr. Sareen said, in my hospital, which I'm affiliated with in New York, the person who's in charge of the medical side of liver transplant, I contacted him and he said, yeah, Dr. Sareen is my mentor, Dr. Sanjaya Satpathy. So I would like you to invite you to please come on the stage. Dr. Dara.
Can I have presentation, please? Hello. It's an honor to speak about my presentation, especially in the presence of our NMC chair, Dr. Gangal sir. Actually, sir, if any mistakes I make, please excuse me. So the medical education is a transfer of knowledge is for public health. It's not for a public health. So the more transfer knowledge to the students, we're saving the people. That's what it is. And that public health is the mission of national medical boards in USA. They're doing the research. So does NMC, NBME, AIIMS, and all your medical colleges. Their public health reason, we're doing the assessment and medical education. So I did my own research. I'm presenting some information that I learned. And there's so many good things in our Indian systems. And then there's some gaps that we're presenting to the policymakers and faculty. Next slide, please. Oh, do I press anything? Enter. So I have no financial interest or relationship to disclose. So learning objectives, there are a few of them. I'm going to go one by one. Mandatory departments in medical colleges. I will explain that later. And medical college in each district, that's NMC and Modi ji government taken. And every district, our medical college, every district means is a public health. In Caribbean, medical college is just put 2 years and shift it out. So minimum medical hospital is a mandatory. That's the whole world need to learn. Even medical colleges in USA, DO medical college, they have no hospital. They have to go around it. So we are way ahead of that. Our concept is excellent. Research gaps, we thank NMC started the BCBR course, mandatory. So we're also submitting, we need the research starting undergrad. So they're looking into that. So how to involve the research from the first year onwards. And digital education and self-assessment. Of course, we know Harvard also, they're learning themselves, classrooms. So we're trying to present the data. And workforce publications, which specialty need what the country, so that need to be published. We need to requesting the like a pediatric association or all areas, they have to put down their research and publication, so that will help the NMC to make their decision. And in the USA, we have if we have a car have a maintenance. Our bike has a maintenance. Our society need a maintenance. India have a lifetime membership. After 40 years, have no value. All Western countries have yearly memberships. So that way, the financial is more viable our own society versus depending on the pharmacy. So the bottom line is transfer of knowledge. I will give a simple example. Our MBB student, after 4.5 years, he want to take step mall. They take a 6 months off, prepare to pass. But USA, once they joined, within 24 months, 96% of them passing, because their assessments similar take the final exam from the day one. So that's why we have struggle of next implementing. Students are apprehensive. So if we can change that assessment wording to the earlier one, so that might change. That will help us, because our kids are very smart. I mean, I even calculate the number of intelligent wise IQ score wise. Our kids are amazing. So that's so mandated departments. So these are the MBBS. This is the only country we have 21 different mandated departments, and most of the preclinicals every country has it. Anatomy, physiology, biochemistry, or paramedical. Core subject like medicine, pediatrics, surgery, OB, and psychiatry is pretty common, but the other departments are not common in other countries. Dermatology is not common. That's why we have much more PG seats. Tuberculosis respiratory disease is unique to our country. That's what the people, they traveled as a lot of COVID patients, and they're there every city treating the respiratory diseases. ENT, madam is from ENT. Every town, every have ENT physician, because we have mandatory department. Ophthalmology, again, we have mandatory. Anesthesia, serving not only anesthesia, critical care, and other departments. And emergency medicine started, and that's also improving. And this is the PG seats. In ophthalmology, you can see 2,434 seats in India compared to US 500. So ENT, radiology, pulmonary, orthopedics, anesthesia, dermatology, they're much more numbers are there. As the new colleges can, more seats will be there. So these are sufficient numbers. But still we are like 30 to 40% less PG seats. Why? And we thank NMC, we thank Health Ministry. They are looking into, in the future of every MBBS student should be postgraduate seats. So we really thank for their vision. So the mandated departments are very successful. And emergency medicine, there's something I want to mention. The EMT technician is a doctor from a hospital, from a house to the hospital. I just saw the published article from our government. Ambulances are every country everywhere, but the faculty which are trained are only 3%. So in order to train the EMT technician, you need emergency medicine department. In order to need department, PGs, they can, so all 700 medical colleges, 10, 15 each trained, we have 10,000 that will produce. So that's where they can treat me if I have acute MI, if my ST elevation, there was a treatment, stay me versus not, which ambulance to go. If I have snake bite, 10 America, 10 people die every year. India, 20,000 dies. But the EMT there to educate them, bring them within an hour, everybody survives. So there is a role for that. So these are all interconnected. The health, NMC versus medical education. The other two things are family medicine, which are requesting. They are very open to looking into the issue. And there are also coordination. We have 30% of the beds are used for medical education. Dr. Vinod Pal sir said, like Australia and other countries use more of the beds. And NBMB use private hospitals, so there may be some of the coordinations need to be there. So we talked about emergency medicine, which is already there. They're already taking good care of it. And there are 35 specialists in USA, but I'll go into fast forward. And there are no practical exams for these specialties except surgical specialties. And these are the different specialties, and you have questions are there 200. There's a they do mock exam questions 200 every year. PG 1 year, PG second, PG third. The final theory will be like that. They have 94% pass rate, and all these specialties are. So NMC planned next examination, and the curve is will be behind compared to the USA, and these can be tested, computer-based tested with higher knowledge, So we were requesting them to look into that. So nationalized subject exam, nationalized item writing, nationalized exit examination, post-graduation nationalized formatting exam, nationalized postgrad exit theory, and specialty also. Research, as I mentioned, one of the greatest example, BCBR by NMC, and by this done by ICMR, and we're requesting to start undergrad also, so that we can start research from the high school onwards. And we like to present not only this medicine, nursing, and paramedics too. And I'll stop there. Thank you so much.
So I'm sure that we are going to be hearing much more about that in the forum that's following lunch today. And especially for the medical students, some of you were asking me in the back about what's our future going to look like. So you can probably start getting some shape of what the future is going to look like in the next few years, what's coming up in terms of examinations and career choices and availability of PG seats and all of that stuff. I'm sure you have a lot of anxiety about that. Thank you, Dr. Adara, for that presentation. So now, if I will have the privilege of introducing Dr. Shiv Sareen, an eminent hepatologist, like I mentioned earlier. He is a Padma Bhushan. He has received the Shanti Swarup Bhatnagar Award. He has created the Institute of Liver and Biliary Sciences, was a huge center concentrating on the treatment of liver and related diseases. Dr. Sareen, thank you.
Thank you, Dr. Chabra and Api for inviting, and I learned a lot in my few minutes, including Dr. Chanchal's talk and Dr. Abra's, and I bring greetings from ILBS. It's a dedicated liver university, probably the only liver university globally. I have nothing to disclose except that our residents are smarter than the faculty and they are ranked second after AIIMS Delhi. I also would like to briefly mention before I start about the National Academy of Medical Sciences where I work, and I want to indulge with API on this. It's your umbrella medical academy. It fosters and utilizes academic excellence, and it has fellowships, associate fellowships, and international fellowships. It's like the most prestigious for foreigners, NRIs, and OICs. And we also have emeritus professors, national quiz, exchange programs, and lot many things. I would recommend, I request, urge you to join and enrich your own national academy. For the talk on liver fat and framing the body, I'll briefly go through. Please ignore if you find it too basic. Liver regulates synthesis, detoxification, and also makes bile. But very few would concentrate that the blood sugar is regulated by liver. And what damages liver is alcohol, you know it well, viruses, and you also know fat. But let me go through some of this. What is surplus fat, how it harms the liver and rest of the body. So normal liver has less than 5% fat, and if because of excess calories or genes you get more than 10% fat, it's an enlarged liver, which is a fatty liver, and this is also altered bacteria. Now this is the journey of surplus fat in the liver. So these are all liver biopsies. It show that all these white cells are fat containing cells. This is a fatty liver. The body doesn't like, the immune system comes and kills these hepatocytes. This is hepatitis due to fat. And you read it into the blood by increased ALT. This is healed by scar formation. This is fibrosis or fibrosis stage 1, 2, 3, 4. And it can go on to cirrhosis, liver cancer. The highest rate of liver cancers is due to NAFLD, and then you need transplant. And just in the European community, this recently published, the public health cost of this journey is about 20,000 million euros. Now, the fat influences the rest of the body. So, when you have extra fat, the insulin cannot get into the liver cell to utilize your carbohydrates, your sugar. More and more insulin is produced by the pancreas, and over a period of time, this insulin resistance leads to exhaustion of pancreas, and you get diabetes. This is a simple diagram, and I want you to remember, you get up and you get your blood sugar done, and you find, oh, my blood sugar is 95, I'm very happy. But you must know how much insulin your pancreas has produced overnight. If it makes 2 units, there is no fat in the liver cells. This is a good liver. But if you have fat in the liver, then you make more and more insulin, and then what you have is 20 units required for keeping your blood sugar at 95. So whenever you get your blood sugar, get your serum insulin done to know if you have insulin resistance. And this is your signature. So diabetes, we believe, is a liver disease due to prolonged insulin resistance. Now, what happens other than diabetes? So you go and get your blood, your cholesterol is high, sir, your triglycerides are high, you pop a pill, but never ask a question, from where has this extra fat come? Well, this is a spillover in very crude terms from the liver. So high cholesterol, high triglyceride, everyone has fat in the liver. Then this fat circulates and deposits on the arteries, and you get blood pressure, you get heart, kidney, bone, cancers, stroke, and gallstone. Gallstone is a liver disease. So fatty liver, in our opinion, is a core to all non-communicable diseases and is the most important public health issue world over. Let's also understand some part of the adipose tissue. So there is in non-alcoholic fatty liver disease, there is more cytokine release and insulin resistance. But there is also dysfunctional adipose tissue. You're not using your muscles or your fat, and this releases lot of cytokines, especially the macrophages travel. To put it, there is adiposopathy. So the ectopic extra fat deposits where? Please note these areas: the subcutaneous part, the visceral part, and the retroperitoneal part of your abdomen. And this is ectopic. This is not normal. So besides liver, you get your muscle. If your muscle has intramuscular adipose tissue of more than 6%, you get insulin resistance, 8%, you get cardiac events. So muscle also should not have fat, pancreas, and of course the perivascular fat. Just some instances, this recent publication, if there is fat in the liver, the cardiovascular events, non-fatal or fatal, are many times more. So people with fatty liver die not due to fatty liver but cardiovascular problems. Let's look at the kidney disease. If there is fatty liver, 41% increased incidence of CKD in 3 to 5 years. You don't want CKD. Extrahepatic cancers. These data of 182,000 individuals, 1/4 had fatty liver, followed for about 6 years. GI cancers, esophageal or colonic, several fold higher. Also lung, breast, other cancers are high. Fundamentally, it is inflammation of the body. To summarize this part, liver fat precedes diabetes and heart disease by 15 to 20 years. You see a kid, 10-year-old, fatty liver, you can write his Janam Patri. If you have fatty liver already, prevent development of diabetes, blood pressure, heart disease, CKD, and cancers. And you already have diabetes, blood pressure, of course, try to reverse by losing fat. So join hands. So this is the key which is all published now in Science and Nature, that fatty liver is core, and you get all other diseases related to this. That includes your snoring, sleep apnea, dementia, and all other Alzheimer's related diseases. So let me summarize. Liver controls your metabolism, your sugar, and your fat. More than 10% fat? No. Liver fat precedes and contributes to metabolic syndrome and is core. Let's look at the problem. So this is Nature review. Now there is more data, 38%, but countries which have more than or equal to 30% of the population with fatty liver, some of US, but India. 1 in 3 Indians have fatty liver, and it is estimated that almost 43 crores people, and between 15 and 24, 23 crores may have fatty liver. In the Indian youth, we did a survey under this major program, Stronger India through a million health educated students, called SMILES. This is Delhi, 12,000 young college students. 31% had either family history of blood pressure, diabetes, dyslipidemia. Those who are in red line, those who are in yellow line make 30% of India is unhealthy. API can join. API can support to make India healthy. This is the liver cancer. This is published. The country where fatty liver constitutes 35 to 40% of all liver cancers, India. This is our WHO collaborative centers data. Today, the commonest cause of liver cancer is diabetes and fatty liver. Doesn't it pain you? This is the data of somewhere 90s and 2000, where 10% to 20% of the Indians had fatty liver. But today, liver cancer, metabolic dysfunction is the commonest cause. This is Nature Reviews. India constitutes more than 30% as fatty liver and liver cancer. Now, this is an important slide, and I want you to pay 1 minute on this. Visceral fat, where is it? Subcutaneous, inside your tummy. Visceral fat is more than subcutaneous fat. This obese guy is bad. But same obese guys, his subcutaneous fat is less, his visceral fat is less than subcutaneous fat. He is okay. Now you have a healthy guy whose BMI is 18 to 23, less than 23. He can be metabolically obese, although body weight is all right. So you have a lean or normal weight but metabolically unhealthy. 20% Indians. And let me show you this important diagram. Red color indicates muscle, green is subcute fat, and blue is visceral fat. Both these guys have same BMI of 22. This guy has muscles, less subcute or less visceral fat. This guy, same BMI, you can see all this blue. His visceral adipose tissue is 5 times more. You say there was a guy, sir, I know, 24 साल का था, पतला दुबला था, blood pressure हो गया. 28 साल का था, heart attack हो गया, पतला दुबला था. All these lean are not always healthy. This is the way we analyze. Now, this guy is body mass composition, and you will see his BMI is just 26%. He doesn't have muscles in the arms, and his muscle is 7 kilograms less, and his fat is 18 kilograms more than it is required, and his visceral fat is much more, 40% more. The simple 1 minute test. Do it, API can support it. How to know fatty liver or NAFLD? First is self-test. I recommend each one of you can train your own people. Self-test. If your family or yourself have obesity, diabetes, blood pressure, heart, kidney or liver disease, cancers, or polycystic ovary, you have it. If your weight is height minus 100 is normal. If you're 170, your weight should be 70, normal, no family history. But if there is family history, your weight should be 65. If you are a female, then 5 more, you should be 60 kilogram for a height of 170. If you remember this, if you are over, you are fatty liver. The simple test is an ultrasound, a fibroscan, a simple blood test, ALT 30, not 40. For females, 19. If you have high lipids, high sugar, you are having fatty liver. So this is simple, everybody can do it. So this is the way we look at fatty liver and problems. All diabetics, fatty liver. All overweight above 23 BMI have fatty liver. Those who have BMI of less than 23, waist, blood pressure, TG, A1C or family history. If you keep this slide with you, you will be through with it. So what is the waist height? Waist less than 90 for male, measured here, and female less than 80, waist to height ratio of 0.7. Learn and teach. Fibroscan, all of you are aware, this is an ultrasound, simple machine, takes a minute, and this shows you controlled attenuation parameter. So when the sound goes, fat attenuates the return of the sound. It should be 220 normally, upper limit is 250, 306 means you have 30 to 40% of your liver as fat. This is fibrosis. 60 milliseconds is the time the sound should come back. Harder the liver, faster the sound returns, and this is 40 milliseconds. This is 8.5. Less than 6 is normal, 3 is good. 8.5 is a stage 2 fibrosis of liver, and this correlates with all firmness of your body. Heart is firm, kidney is firm, brain is firm. So when the person goes to a primary health care center, PHC level, anywhere, you just require what is called as FIB4. What is FIB4? Age, AST, platelet and ALT. This is globally the simplest and cheapest. If FIB4 is less than 1.3, you are through. Come once in 2 years. If FIB4 is above 1.3, then you may need a fibroscan. A fibroscan can tell you, this is our algorithm, a fibroscan will tell you if it is less than 8, come in 1 year. If it is 8 or above, stage 2 fibrosis, you need to go to a specialist. So very simple, FIB4. After that, you may need a fibro 8 or less than 8. And this is just to tell you, longer the duration of diabetes, more are the liver related events. I am not showing you for any details, and this depends on the age also. The summary 2, 1 in 3 adults and 1 in 5 children in India have NAFLD, the commonest cause of cancer, and you may also have lean people with family history with fatty liver. Do a self-test and a FIB4 and a fibroscan. The last part in the last 2-3 minutes is the national program and how API can handhold, support. Efforts by Indians in India, I am telling you, in the US, you will have to start. So in 2021, February, we were able to integrate the fatty liver screening in the national programs. And this was a groundbreaking initiative. This made India the number 1 country in the world. No other country had started this. We started 2.5 years ago, and we got 49 out of 100 marks, while Britain got 41. 33 countries got 0. Why should you do all this work? This is a long study from Korea of 3 million Koreans done for 4 or 5 years. They did a fatty liver index which included body mass, waist, TG and gamma GT, another liver test. those people who did not have fatty liver but got fatty liver, in them diabetes development was twice, heart attack was more, stroke was more, death was more. But most important is those people who had fatty liver and it regressed, death reduced by 17%. So the strategies in India today are bottom-up approach. The ASHA worker, the Anganwadi worker is just going to screen for risk factor, those self-test. She will refer. Then you will go to the community health center and then the person goes to the district. And this was the proposal which got into Lancet. I want API to support these programs. This will be a game changer. This is my last slide to show you how do we control fatty liver to reduce the NCD burden. We every year check diabetes is rising, cancers are rising. Can we stabilize or can we reduce? This is 2021 and by 2033 we may like healthcare workers, doctors to understand the vital role and we should be able to reduce our diabetes, blood pressure, heart disease, all these ailments. I want API to play a very strong role into the programs, into the education and hand-holding, both in India and in the US. Thank you for your kind attention.
Thank you, sir. Just one question. Is it reversible, fatty liver? And how do we go about it?
Yeah. Thank you for asking that. It is reversible, absolutely reversible. Those who are lean, it may be difficult. They lose 5% weight, and of course, there are drugs. But those who are on the other side may need to lose 10% to 20% of the weight. Man goes away.
Thank you. That was excellent. Thank you. So I would request all the speakers to be here, and we would like to present a little token of appreciation for participating in today's series. Thank you. And may I invite some of our API leadership, Dr. Sumul Rawal, Dr. Bhavani, Dr. Srini Gangasani, please come upstairs and to hand over the little tokens of appreciation to our speakers. Thank you. Oh, okay.
And also Dr. Gangadhar sir. Okay. You will come on stage. Yeah.
May I request Gangadhar sir to hand over the memento to Dr. Lokesh Idara? Now may I request Dr. Sumul to kindly hand over the memento to Dr. Chanchal. May I request Dr. Bhavani to hand over memento to Dr. Inderpal? May I request Dr. Srini to please hand over the memento to Dr. Shiv Sarin?